Good afternoon. Welcome to the first Script Your Future webinar for healthcare professionals, medication adherence in practice. Hello, I'm Rebecca Burkholder, Vice President of Health Policy for the National Consumers League, home of the Script Your Future campaign. Thank you all for joining us today. Today's webinar is packed full of information. We will first give a brief overview of the Script Your Future campaign and then introduce today's speaker. We are pleased to have Dr. Ira Wilson as today's presenter. Dr. Wilson's talk will be followed by a question and answer period. Before we get started, we would like to go over a few logistical items. We are pleased that over 300 people have signed up for the webinar. You are all in listen-only mode, but if you have a question about the presentation, and we encourage you to be thinking of a question, please use the chat box that is in the upper right-hand corner of your screen. You may need to click on the orange arrow on your screen to open it. You can send your question at any time, and we will try to get to as many as we can during the Q&A time period. If you have any technical difficulties during the webinar, please email ayanaj@nclnet.org. Today's webinar is being recorded and will be available after today's session on our website, scriptyourfuture.org. To start off, a bit of background about the campaign. The National Consumers League, the organization that leads this campaign, is a consumer advocacy organization founded over 100 years ago in 1899. For decades, NCL has worked to help consumers understand and use prescription and over-the-counter medications safely. NCL recognized what a huge public health problem poor adherence is and began planning this campaign over 5 years ago with initial support from the Agency for Healthcare Research and Quality. With the involvement of dozens of stakeholders, researchers, and experts, we devised the campaign, the first ever broad-based public-facing campaign to help address this issue. Building on past research and new research with patients, caregivers, and healthcare professionals, and in partnership with the other stakeholders, we built the campaign creative outreach. Script Your Future launched nationally in May 2011 with the objective of raising awareness of the importance of taking medication as directed. Our target audiences are patients with chronic conditions, including respiratory and cardiovascular conditions and diabetes, family caregivers, and of course, healthcare professionals, the pharmacists, doctors, nurses, nurse practitioners, and others who help patients manage their medications. The campaign is a national campaign and also has focused outreach in 6 target markets, including Baltimore, Birmingham, Cincinnati, Providence, Raleigh, and Sacramento. What makes this campaign truly unique and gives it much breadth and depth is the involvement of our committed partners. To date, we have over 135 committed partners, including healthcare professional organizations, consumer and patient groups, businesses, pharmaceutical companies, insurers, government agencies, and adherence researchers. The Script Your Future campaign raises awareness about the importance of medication adherence by focusing on the consequences of not taking medication. Our consumer materials reflect the I Will theme, encouraging people to pledge to take their medications for reasons that matter to them and to talk to their healthcare professionals about their health conditions and medications, opening up that all-important dialogue. By personalizing the goals of therapy, the reasons for taking medications will matter to each patient. It is not just because the doctor or pharmacist said so. Our campaign website, scriptyourfuture.org, offers tools and information, including free text message reminders and interactive videos on chronic conditions. Visitors can also take the pledge to take their meds and download adherence tools. Additional campaign materials include public service announcements with the Surgeon General, posters, and our very popular wallet card. The card includes the pledge, a chart to keep track of medications, and a list of questions to ask a healthcare professional. We encourage consumers that if they have questions about a health problem, how a medicine works, side effects, or other concerns, to talk to their healthcare professional. The cards are now available not only in English, but also Spanish, as well as Chinese, Vietnamese, and Hmong. And starting this week, we are partnering with the FDA and the Federal Citizens Information Center at Pueblo, Colorado, to offer for free our wallet cards and more to help facilitate conversations with patients. Visit our website to find out more and about how to order these materials. And now, as part of the campaign's ongoing effort to encourage healthcare professionals to talk with their patients about their medications, we are pleased to introduce our speaker for today, Dr. Ira Wilson. Dr. Wilson graduated from Harvard Medical School in 1987 and completed a residency in internal medicine at Beth Israel in Boston. Dr. Wilson was chief medical resident at Beth Israel and a fellow in the Harvard General Medicine program. In 1993, he joined the faculty at Tufts Medical Center, where he rose to the rank of professor in 2006. In 2010, he moved to Brown University, where he is the chair of the Department of Health Services Policy and Practice. Dr. Wilson has been a practicing physician for nearly 20 years, most recently at the VA Hospital in Providence, Rhode Island. Dr. Wilson, welcome.
Well, thank you. Can everybody hear me okay?
Yes, we can.
Okay. Well, thank you all very much for logging in and for your interest in this topic of medication adherence. And as an aside, I really do recommend that you have a look at the materials on the scriptyourfuture.org site. Let me also say by way of introduction that although this presentation is focused mostly on physicians, that if there are pharmacists, nurse practitioners, or other prescribers on the call, the messages for you are absolutely identical. So most of the time that I talk with fellow providers about medication adherence, and I say that because I still practice, I usually start in a somewhat traditional way by building the case that medication adherence is important and that we have to do better at it. That involves reviewing the literature, showing some data, and so on. But I want to do something a little bit different today. I'm only going to spend a few minutes on the introduction and background, and instead I want to spend most of my time sharing some ideas and concepts with you all that are hopefully new and different. Next slide. Okay, so why is this topic important? So a bit of background. I just want to note a few obvious things that you probably already know well. First, and perhaps most importantly, this is valuable because we want to do good for our patients, and taking medications that are known to be effective is generally a good thing. Second, much of medical practice for providers today is the care of persons with chronic conditions, and most of what is done for chronic conditions are a combination of treating with the right medications and behavioral changes. Third, payment systems are moving from payment for process to payment for outcomes. And many of the outcomes that are being measured, like blood pressure control for hypertensives and hemoglobin A1C control for persons with diabetes, depend very much on medication adherence. Fourth, there's good evidence that we as providers really don't do this as well as we could and probably should. I'm not going to review the evidence for this today. That's subject of a different talk, but I hope you'll accept the premise that there's more that we as providers can do to improve our patients' adherence. However, there is some evidence about what kind of adherence interventions work. Next slide. Okay, so for example, in 2008, a Cochrane review led by Brian Haynes concluded that, quote, current methods for improving adherence to chronic health outcomes are mostly complex and not very effective. A more recent overview published in 2012 in the Annals of Internal Medicine concluded as follows. Reduced outpatient out-of-pocket expenses, case management, and patient education with behavioral support all improved medication adherence for one or more conditions. Evidence is limited on whether these approaches are broadly applicable or affect long-term medication adherence and health outcomes, end quote. So there is some good research about how to improve adherence, but in general, These interventions, as you may know if you've read these reviews, require organizations, structures within which the interventions occur, and not insubstantial resources. So I have done and continue to do some of these studies, and I'm all in favor of improving systems to improve care quality. But what I want to talk about today are the conversations that you have with your patients, regardless of where you practice, where your practice is, or what your practice setting is. There are things that I believe that you can do that can make a big difference for your patients, even in the absence of more structured interventions and systems that support these interventions. I also want to be a little bit disruptive. I'm going to suggest some ways of thinking about the problem that may be somewhat different from what you're used to. Now, nothing I'm going to suggest is intended to really disrupt your practice per se, but some of the things I'm going to suggest may take a while to get your mind around. And perhaps most importantly, I really want to be practical. I want to suggest some things that you can test this afternoon or tomorrow morning, whenever you see your next patient. To try these things, you don't need planning, reorganization, patients at our medical homes, teamwork, or anything. You really just need to have the courage to have some new and different conversations. And there's no reason why you can't start changing the conversations that you have with your patients immediately. While everything I talk about today may not be evidence-based, because as I just noted, most of the intervention evidence relates to more complex interventions that are patient and not physician-focused. But everything that I will talk about does have a strong basis in current theory. The underlying principles include many that you all have heard about or maybe even be quite familiar with or even teach. They include motivational interviewing, adult learning theory, patient-centered care, and shared decision-making. We don't have time today to work through each one of these concepts, but if you're already familiar with these concepts, you'll see how they are very much embodied in what I want to propose today. But as those of you who have some familiarity with these concepts also know very well, implementing them in the sort of chaos and rush of daily clinical practice is really quite challenging. So, what can we do in the course of 15-minute office or pharmacy visits that are packed with other things to improve our patients' medication adherence? I believe quite a lot. As a starting point, let me propose that we have to change our thinking. We as providers have deep expertise in the diagnosis and treatment of disease and in medication prescribing. And I would argue that the model we all carry with us in our minds is that the goal of care is to communicate this deep knowledge to patients. The problem is that we do this with very limited Okay, can everybody hear me? There was some feedback there. Okay, let me continue. So I was going to say that the model that we carry with us in our mind is that the goal of care is to communicate this knowledge to patients. But the problem is that we do this with rather limited effectiveness. For example, we know that close to 30% of patients never even pick up a first prescription at the pharmacy, known as primary non-adherence. And we also know that patients take chronic medicines only about 50% of the time. So let me suggest that our basic model is deeply flawed. And let me suggest that it is flawed because it focuses mostly on the physician and on physician or provider or prescriber expertise. What the medical model does not recognize, understand, or incorporate is the patient's expertise. So what do I mean by patient's expertise? The patient's job, as you all know, is to implement medication regimens in the face of many barriers. These include problems getting in touch with us for refills and questions, cost problems, problems with formularies, competing life circumstances like jobs and caring for aging parents and children, stress, anxiety, depression, substance abuse, or serious mental illnesses, side effects and complications of therapies, and the list goes on. You all can make certainly as good a list as anyone. And I'm in no way suggesting that what I just mentioned is a complete or an exhaustive list. So what are patients experts in? They are actually experts in all of the things I described in the previous slide. And furthermore, and critically, they are the only experts in all of these things. So interestingly, they are the sole source of information that we need to do our job as providers. Furthermore, many patients have years, even decades of experience with asthma, diabetes, hypertension, or the conditions we treat. And they actually live with these diagnoses and with our treatments 24/7. So this is one of the most important bullets in today's presentation, which is why I put it in red. If you remember only one thing from today, remember this. Patients will not take medicines as you would like them to until they believe that you understand and respect their expertise. Now, my suspicion is that most of you wouldn't argue with this, and you may even think of this idea as a core belief or an important tenet of how you practice. But what we've learned in recording and analyzing hundreds of physician-patient visits and in qualitative research with both patients and physicians is that it is extremely difficult to actually put this into practice in the crush of seeing patients every day. So now, let's get really concrete and practical. I hope in the rest of the presentation to give you some new ideas about how to do this more effectively and actually quickly in real time. I want to suggest that medication adherence involves three kinds of conversations, and they all can be difficult. The first is how to ask about adherence, how to get the adherence conversation started. The second is how to do adherence problem solving or troubleshooting related to adherence. And the third is how to inform or educate our patients about medication adherence. Now let's try to unpack these three tricky conversations. First, do you ask about adherence? In audio-recorded visits of HIV care, in which physicians sign informed consents and they know that they're participating in an adherence study and that we're interested in adherence dialogue, they still often don't ask about adherence at all. I dare say you all have lots of thoughts about why we don't ask about adherence as much as we probably should. Second, when you do ask, how do you ask about adherence? What does it actually feel like when you ask about a patient about adherence? For most of us, and I certainly speak for myself, it can feel a little uncomfortable. For example, don't you sometimes have the sense that even just asking a question is in itself kind of an expression of distrust, kind of an assertion that the patient is not doing their part, not holding up their end of the bargain, or maybe even being a little bit untruthful? So how can we do this better? Let me suggest something easy that I bet most of you have never tried. Try asking an open-ended question that only the patient can answer and for which there is no right or correct answer. What do I mean by that? Here are some examples. How do you think these medications are working for you? What's it been like for you to take all these medicines? How does taking these medications make you feel? What's the worst or hardest thing for you about taking these medicines? My favorite one is actually the first one. How do you think these medications are working for you? Whenever I see a new patient and I ask this question, I get this sort of quizzical look. One patient asked me the other day, do you really want to know? Are you sure? And then he went on to tell me his views on each of his diagnoses, the medications that he was getting for each, including which ones he didn't think were working and exactly why he didn't think they were working. Another patient recently said to me, he goes, you mean you want my opinion about how these are working? There's a pause. And he said, He said, no one ever asked me that before. There's another pause. And he said, well, I guess I don't think they're doing much. And then there's another pause. He said, except making it hard for me to, have sex. So do you see what you're doing with this approach? By asking a question that has no right answer, you're asking them to share their expertise with you. If you just give this a try, I actually think you'll be amazed at how powerful it can be. The most important thing to do next is ask another clarifying question. It turns out that this is actually quite difficult. It's difficult because the natural instinct of all of us who want our patients to have accurate and timely information and to be knowledgeable is to jump right in to correct one or more of the misunderstandings that often, although not always, are part of what patients say in response to open-ended questions of this kind. In motivational interviewing, which some of you may have experience with, they call this the writing reflex. And they advise providers to, quote, avoid the writing reflex, end quote, because before patients can be corrected, they actually need to be accurately understood. And until patients feel understood, that their own expertise is respected, they're not likely to be very open-minded about our suggestions, nor arguably should they be. Examples of clarifying questions are what you might expect. Tell me more. Can you tell me more about what that's like for you? How does that affect you on a daily basis? How does that make it hard for you to take care of your kids or go to work every day? What do you do when that happens? How do you handle that? And there are many, many more that I'm sure you can think of or maybe even use. But I think you can see the strategy here. You're listening actively and really trying to understand the patient's thinking from their point of view. So as physicians, we love to solve mysteries and make diagnoses and to figure things out. So be a detective. But here's the thing. Don't be a detective about whether or not they're taking their medicines. Instead, be authentically curious about their life and how they are experiencing taking the medicines that you're prescribing. In many places, you'll see recommendations that you should ask about whether there are adherence problems with suggestions about how to do this in a sort of a balanced and a non-judging way. And then, if and when a patient admits to a problem, asking why. So one problem with this approach, as I noted previously, is that it can be uncomfortable. But the biggest problem is simply that it usually fails. Just doesn't work. It turns out to be a conversation stopper rather than a conversation starter. And I would be stunned if most of you aren't already very familiar with what a conversation stopper this can be. So my suggestion is try flipping this entirely. First, ask your patients to share their experiences of medication taking with you. And if the patients are convinced that you are really listening and really understand their perspective, that is, that you're truly respectful of their expertise, then it's my experience that issues, problems, and questions emerge naturally and also quickly. Now let's move on to the second difficult conversation, how to do problem solving. Let me suggest a way to think about medication taking that can simplify an otherwise rather complicated set of issues related to adherence problem solving. I want to propose that three things have to happen for patients to successfully and consistently take medications. First, patients have to accept and understand their diagnosis. Second, they have to choose to be treated. And third, they have to implement treatment. Now, let's try to unpack these one at a time. As providers, we deal with diagnoses all the time. And because of that, we can easily forget what it means for a patient to get a diagnosis. For a patient, a diagnosis is a lot more than a label. It's a change in their identity, their personhood, their sense of self. And accepting and integrating a diagnosis into their life often happens rather slowly. Think about how being diagnosed with diabetes or HIV or cancer or bipolar disease literally changes the future for that patient. Or take something even simpler. In my experience, one of the most difficult populations to treat is an otherwise completely healthy 45-year-old man who for the first time has hypertension. The reason it's difficult is because it's so hard for many men in this age group to process the fact that, you know, they're no longer 18 years old and now have a chronic disease that requires a chronic treatment. It can take actually years to accept that new identity and fully engage in treatment. And hypertension, of course, is common and highly treatable. In contrast, many diagnoses involve terrible stigma. Think about the stigma of depression or a substance abuse disorder. But it goes beyond accepting the diagnosis and assuming that new identity. Before treatment's possible, patients need to understand the implications of that diagnosis for their health, the nature of the threat that it poses, and the time course of that threat. And if you think about how difficult it is to accomplish these tasks and how little time and attention we actually give to these issues in the course of a routine visit, it becomes more and more clear why 30% of patients don't even pick up an initial prescription. So I would argue that discussions about choosing treatment are pretty much a waste of time and waste of effort if a patient doesn't understand and accept their diagnosis and have a sense that it's appropriate to start doing something about it. But once a patient is ready to think about treatment, there are still at least two big issues. The first is whether to start treatment now or to wait. For example, patients with hypertension or diabetes may want to try to lose weight or exercise before starting medications. Unfortunately, we don't have time to discuss the evidence for this today, but research that we and others have done suggests quite strongly that many patients look at us as pill pushers who really do the bidding of the pharmaceutical industry. So even if it's our experience that most of the time patients actually don't lose weight or start exercising, remember, this is really not our decision to make. Next, if the patient chooses treatment, then there are decisions to be made about which treatment. As we all know, drug treatments of most conditions have a variety of approaches with a variety of pluses and minuses. Virtually every professional organization endorses shared decision-making as desirable. We can't talk a lot about shared decision-making specifically today, but I was just at an international meeting on healthcare communication. I can tell you that research presentations from the US, Europe, and elsewhere in the world all show that it actually rarely happens in real practice. The main thing I want to leave you with here is that if patients don't actively choose to take a medicine and have a clear sense of how it's going to help them, they won't take it for long. I think most of you have a pretty intuitive understanding of this. And finally, if a patient understands and accepts their diagnosis and has actively and knowledgeably chosen a treatment, a lot can still go wrong, unfortunately. People often can't afford medicines. There are logistical problems picking up refills, especially when all of the medicines run out at different times. People who work or otherwise have busy and complex lives can have a hard time figuring out how to integrate medication taking into that complex life. This is obviously particularly true for people with mental diagnosis, substance abuse disorders, unstable housing, financial insecurity, job insecurity, or heavy family responsibilities. And in the face of all these issues, sometimes patients just forget to take pills. Another way to frame this problem-solving part of today's discussion is to remind ourselves that non-adherence can actually be intentional. When patients haven't accepted that they have a condition that merits treatment and haven't actively chosen a treatment, then non-adherence is in fact mostly intentional. When they actually want to take a medicine and can't seem to do it consistently, that is, they have an implementation problem, then you can think of that as unintentional non-adherence. But here's the problem. One can masquerade as the other. My experience is that the first two steps in this three-step proposed pathway are where most of the problems lie. But what's the most common response when you ask patients why they aren't taking their medicines? They forget, right? They just say, "Doc, I can't remember," right? Isn't that mostly what you hear? Well, I think this is the most common response because it's what sounds good, and it kind of gets us off their back. And in fact, we as providers are pretty comfortable suggesting pill boxes, reminders, and other practical things. It isn't so comfortable for a patient to say things like, "You know, Doc, I don't really think I have hypertension." Or, "You know, I know you recommended it, but I don't really want to take medications for my diabetes." So try something. When patients say that they forget, start at the beginning and ask them what they understand about their condition or diagnosis. When I do this, I almost always find that there are large and important gaps in their understanding. That is, problems in the first two steps of the process. Before moving on to the next topic, I hasten to remind you that patients can, of course, have issues with more than one of these steps at any given time. For example, they can be both confused about their diagnosis and have a chaotic life. Second, patients can have different causal and explanatory models for different medications. So Don't assume that what you learn about an antihypertensive will generalize necessarily to their statin or to their antidepressant. Third, things can and will change over time in response to all kinds of factors like conversations with friends, news reports, and things they've learned online. So it's useful to update your impressions and your understanding on a regular basis. Now let's turn to things we can do to inform more effectively. Let me suggest that you think about informing or educating in a new way. Start by asking patients what they know. Then ask them what they would like to know. And only after those first two steps, get to what you think they need to know. Finding out what patients know can be really quite interesting, and sometimes they're incredibly knowledgeable. Hearing about that knowledge, that information from them, not only saves you lots of time, but it gives you the opportunity to be supportive of their interest in and their knowledge about their condition. To get them to feel comfortable talking about what they know, you do have to demonstrate a sincere interest in learning what they know and to be an active listener. There are a variety of ways to get this conversation going, but I think it's useful to start with a recognition that they probably thought quite a lot about their health issues, and that's generally true. So questions I like are the following. You've probably thought a lot about diabetes. How do you think about it? Or you probably know a lot about how HIV gets transmitted from one person to another. How do you understand it? Or variations on those themes. Notice that I try not to ask, what do you know about your diabetes? What do you know about HIV transition? Questions like this. They sound a little bit like a pop quiz that has an answer, and you don't want to put the patient on the defensive. So the goals of this conversation are to understand what they know, who they get information from, how strongly they feel about things, and why they feel that way. Perhaps most importantly, you want to understand their causal models, their attributions, how they put things together in their mind. The next step is to find out what questions they have. Examples of how you might ask about that are, you probably have some questions about why you're taking that inhaled steroid. Is there anything you've been wondering about? Or you've probably heard people talk about those new recommendations about how to use, how to treat high cholesterol. What kind of questions do you have about that? As you know, because you're an experienced clinician, people almost always have questions. The problem is that they often don't feel safe and comfortable asking those questions. One approach, which is, we all have a lot of experience with, is saying, any questions? And you know what the usual response is nope, no questions, doc, which doesn't actually help that much, of course. Now, the goal here is to avoid the trap of guessing or assuming what questions patients have, and then giving, the canned 2-minute lectures we all have about common problems that we see every day. Instead, ask them to tell you what questions they have. And I would suggest that they're quite often not the ones you might have thought or anticipated. Now we get to the part that most of us are pretty experienced with, educating and informing. And I know some of you are thinking, yeah, it's about time we got to this part. This is what I'm trained for. This is why patients come to me. This is my job. But there's a reason that I'm getting to this last, and that's because if you start here or you get here too early in the conversation without the right preparation, most of what you say will be wasted breath. It'll go in one ear and out the other. It won't stick, it won't be remembered, and it certainly won't be implemented. If you try what I'm suggesting, there's no doubt that you will learn things about what patients know or think or understand that are incorrect, not right, and that adversely affect treatment. Like my patient who told me he knows when he's hypertensive because it happens when he is hyper and feels tension. Or the patient who didn't understand why it would be rational to use his inhaled steroid every day if it was going to give him fungus in his mouth. Or the patient who stopped taking her alendronate because it didn't help her knee pain, because she had confused osteoporosis with osteoarthritis in her mind. So who was the provider that was responsible for all these dysfunctional communications? Well, me. So let me suggest something else that may strike you here as silly or unnecessary, and that is asking permission to educate or inform. Examples of ways to do this are, can I share a couple thoughts with you about hypertension treatment? Or, would you mind if I shared a couple thoughts with you about this idea that inhaled steroid causes fungus in your mouth? Now, trust me, no one is going to say, no, forget it, doc, I don't want to hear what you have to say. To the contrary, they always say something like, no, of course not. That's why I'm here. But if you do this, you'll feel that there's a very different way, there's a very important way in which this sort of changes the dynamic. You're not lecturing, you're not dictating, you're not scolding. You're actually sharing information. And importantly, it's information that the patient is asked to receive. Now, the last thought I have about giving information is, of course, an old message, don't give too much at one time. And to make sure you check the patient's understanding with simple techniques like teach back, where you ask the patients to teach back to you what you hope they've learned. Now, let's try to summarize the key principles that I've just talked about. First, I suggested that we try to think about medication adherence using a different model, one that focuses not on our expertise as providers, but on patients' expertise. Much of what I've suggested that you try is aimed at having conversations that reveal this expertise. And I've tried to convince you that that process inevitably produces not only tremendous understanding on your part, but trust on the part of the patient. Next, we talked in some detail about how to have three somewhat difficult conversations. The first was getting the adherence conversation started, and the second was how to think about problem solving. I proposed that one way to think about problem solving was to think about three things that have to happen for the patient in order for them to be adherent. One, patients accepting their diagnosis. Two, choosing treatment. And three, implementing treatment. And I emphasize how often problems that seem to be implementation problems have their true roots or true basis in a sort of an incomplete or erroneous understanding of the first two things, accepting the diagnosis and choosing treatment. And finally, we talked about educating or informing. I suggested that you might do it in the following order. First, find out what they know, then find out what they want to know, and only after these first two steps, segue into what you think they need to know. You may be thinking at this point, okay, sounds nice in theory, but this guy Wilson has no idea what my practice is like. I have no time for this kind of stuff. So be honest. I know what it is you're thinking, but the point is that this is a set of concepts, an approach, a strategy, not a set of rules that you have to implement one by one. Think of it like a new set of tools that you can carry out one at a time. If you're going to start somewhere, I'd suggest that you ask every patient for a couple of days one question. You're on quite a few medications. How would you say they're working? And then just listen. You may be surprised how just doing that changes the doctor-centered dynamic into a more patient-centered one. Or when a problem comes up, rather than starting with suggestions, ask about what the patient understands about the underlying condition, why it's worth treating, what they think the medication is supposed to accomplish, and so on. I bet you'll be quite surprised by what you learned. Because most outpatient care is longitudinal. You can actually implement these ideas with a patient little by little over time. Start with one medication, then next work on another one. Another point that I would argue is that this kind of approach will actually get you to the heart of adherence problems quite quickly, and that always saves time. So I would encourage you to play with these ideas, experiment, improve them, make them your own. And finally, if you use some of these ideas, I think you'll actually have more fun. We're all in this profession because we care deeply about our patients and we want to connect with them in ways that make them healthier. So I challenge you to decide that you can and will approach medication adherence differently. All you have to do is have a different kind of conversation. So I thank you for listening today, and I wish you luck with some of these suggestions. And I certainly would love to hear from you about how it goes. As I said at the beginning, I really do recommend that you have a look at the resources on scriptyourfuture.org. Thank you.
Thank you, Dr. Wilson. That was a terrific presentation. Dr. Wilson challenged our audience to take some innovative and new approaches with their patients to focus on patients' expertise. So I'm sure that we will have questions. A couple of reminders for you. The slides are available on the Scripture Future website right now. So you can go to scriptyourfuture.org, and in the upper left hand corner, you will see a slide about this webinar, and you can download the slides. We are also recording this webinar, and that will also be available on our website soon after this webinar concludes. I want to encourage you all that if you have a question, please use the chat box that is in the upper right-hand corner of your screen. You may need to click on the orange arrow on your screen to open it. Please feel free to send a question at any time. We have a good 20 minutes, Ira, for questions, so we will hope to get to as many people as we can. And just want to encourage you that to ask us a question about how to incorporate what Ira has presented into your practice. And again, the slides are available on the scriptyourfuture.org website. So we are getting questions in, and want to kick off with a question from Joe about family caregivers. And Ira, that they play an important role in managing medications, whether it's managing medications for a spouse, for a parent, for a child. How do you include that caregiver in that conversation about adherence? Ira.
Well, it's a great question. Just in terms of relating this to the concepts that we talked about, caregivers often, let's just imagine that a patient can't participate. When a patient can't participate, then all of that thinking and conversation has to happen with a caregiver. But often, caregivers, a patient can communicate, and caregivers and patients actually disagree with each other, or have sort of conflicts about one part or another part of a discussion. You know, I actually love it when a patient comes into my office with a wife or a daughter, and sometimes that's because the patient wants to suggest something that they think might not be popular and might want support. Or another time it's because the two of them are having an argument or a debate about, you know, the usefulness of one thing or another thing. And all I would suggest is that you can involve other caregivers and should involve them in all of the same discussions that we just talked about. It's rich, it's interesting, it's terribly important, and in the same way that it empowers patients, you do have to empower caregivers of all kinds.
Great, thank you, Ira. We do have a next question from Kathy, and the question is, how do you approach a patient if he or she says they are adherent, even if you have evidence that they obviously are not?
Well, so this is an interesting issue, and the way to avoid this sort of confrontation where you think because you've looked at the blood pressure or the hemoglobin A1C or the viral load or a physical exam where you hear all kinds of wheezing and an asthmatic who says, you know, oh no, I'm taking everything, doc. So this idea where you have conflicting evidence is right where this destructive dynamic of you asking a question where you're trying to, it feels like you're trying to pin the patient down and prove to them that you know that they're not taking a medicine. And that just fails. It's very destructive. And so part of the reason that I proposed the methodology that I proposed is that I found it's much easier to not talk about the adherence at all, but rather to talk about what we mentioned, what patients like or dislike about the medicines, whether they think they're working, whether they have any side effects or problems, and often also to back into what they understand about asthma or diabetes or whatever. So personally, I never ask them directly about those things because that conversation is going to fail. we've all experienced that failure time and time again. So we have to think about different ways to do it in ways that are more functional.
Great. Thank you, Ira. The questions are coming in now fast and furiously. Our next question is from Perry. And the question is, what are your thoughts on the growing role of technology, such as mobile applications, to help patients keep up with their medication? This is something I can say with the Script Your Future campaign. We do offer free text reminder services through our website. And we know for certain patients that this can be helpful. But Ira, what would you have to add to that?
So Perry, great question. What I would do is think about technology as a screening test. But not a diagnostic test. So the purpose of technology is to help you figure out who to invest time and energy in. But that time and energy is the conversation we've just been talking about. Because even if you know, because of some irrefutable technology, and of course, no technology is irrefutable. I've used most of them myself in research studies. The best that can be is a conversation starter, because if you know someone's not taking a medicine, that doesn't tell you anything about why. And you can't help solve the problem until you know why. And as I've suggested, just be really careful when the patient starts talking, I'm so busy and I forget. Just back it off and start talking about the basics. Just remember, patients don't forget things that are important to them. So patients don't just forget to pick up their kids at daycare. You know, they don't just forget to go to the market, right? Those things are critical to the functioning of their families. They don't forget them. The fact that they say they forget medicines suggests that they may be lacking a lot of knowledge about the importance or salience of those things. So, so I hope, just back to the technology, think about it as a conversation starter, but you still have to have the same conversation. I hope that makes sense.
Yeah, absolutely makes sense. Thank you, Ira. Just to remind everybody before we get to the next questions that the slides are available on the Script Your Future website. That's scriptyourfuture.org. The slides are available in the top left-hand corner. You'll see a slide about the webinar, and you can click there and download them. Our next question is from Tom. What is your advice to clinicians about how they should vary their approach with patients when they see a patient weeks or months after an initial conversation, like the one you just outlined? Do you have to vary their approach when you're faced with remotivating a patient who might have started off strongly adherent, but whose adherence fell off because of new life circumstances? Ira?
Well, great question, and this happens time with everybody. Someone has a disease that's going to be with them, like diabetes, that's going to be with them for 10 or 20 or 30 years, then it is inevitable that there's going to be all kinds of things that happen. So you should expect this as a normal state of affairs rather than an exception. And I don't have any specific advice rather than to hark back to the earlier discussion and say, and by the way, patients really like it and appreciate it when we remind them and remind each other. This visit, we've reminded what the conversations were in that visit, and that we're following up specifically. We do know from some research that patients can get really, really annoyed when the issues that were the subject of conversation in a previous visit are just completely ignored and sort of treated as being over and done with. So I think it's a great opportunity to say, gee, we talked last time you were here about your asthma and about the difference between the inhaled steroid and the albuterol, which is, remember we talked about it as a rescue inhaler. Do you remember that conversation? What do you remember about it? What thoughts have you had in the meantime? This is a way to sort of get them talking about what they remember, which, by the way, may be little or nothing, in which case you have to go back to the beginning, and also to talk about what's happened in the meantime. which could include conversations with a brother-in-law that said, "Oh my God, don't take that. That's an awful medicine." It could have included going out on the web, detail about the side effects and complications of a medicine. So you really don't know. Exploratory approach, and little by little, sort of rationale behind what a diagnosis is, why we're treating it, why we're using this treatment, and how to customize that for an individual in the course of their life. So great question, Todd.
Great, thank you. Our next question is about how do you suggest, Dr. Wilson, that we share this advice with our colleagues in order to improve compliance with multiple providers, multiple settings? Just knowing your experience, I were working with physicians and other practices. How do you suggest you share, or people that are on this call share this advice with their colleagues?
Well, so I'll give an example. I'll answer that in a somewhat maybe non-conventional way, which is to say that if you implement a different way of practicing, and I decided about 5 years ago that I would completely change the way that I practiced, and so if you do this, it will be pretty clear to your nurses, to your patients, to the people that are talking to your patients who call at night or on call, to the people that see your patients in the hospital. It's actually going to be pretty apparent to them that you're doing something differently. And let me just give you an example. For a number of years, I have spent a lot of energy talking to my patients about the ineffectiveness of antibiotics for colds and bronchitis and so forth. And basically I don't use them, and I didn't use them for a long time. And the nurses in my practice all knew that my patients never called asking for antibiotics. And the other doctors actually learned that my patients never called asking for antibiotics, because the nurses would say, well, how come your patients keep calling about antibiotics when we know they aren't effective in this context? So this is a long way of saying, I think that your role model, that is to say what you do and how what you do transforms the way in which you interact with patients, I actually think that's a whole lot more important than kind of what you say or you urge them to do. I'm not saying, don't share ideas and advice, but role models and examples are really powerful and in ways you might not expect, particularly, by the way, for those of you who practice in settings where residents or medical students or other inexperienced or less experienced providers are being trained.
Great, thank you. This next question is from Danya, and it's asking about how the communication tools that we've addressed have been incorporated into medical school curriculums. And Ira, before I turn this one over to you, I want to make sure people know that Script Your Future has headed up something called the Medication Adherence Teen Challenge, which is a contest for this next generation of healthcare professionals, for pharmacy students, medical students, nursing students, other health profession students. And the challenge is that in the month of February, that they take the Script Your Future materials and go out into their communities and be talking to patients, to other healthcare professionals, to their community about the importance of medication adherence. And our challenge to them is also to do this in very creative ways. So Ira, I'll turn it over to you if you have any more specific information about how this information is really incorporated into the medical school curriculum, so this next generation of healthcare professionals can be more attentive to this issue and more aware of how to talk to patients.
Yeah, thanks for that question, Danya. There, in the intervention work in this area that my group has done, we made a decision that we were not going to intervene with medical students and trainees, that we were going to intervene with sort of grown-up attending physicians, people in practice. And the reason we made this decision has something to do with how medical students get trained. Medical students, as many of you know, because some of you may be doing that training, get generally excellent training in the first 2 years of medical school. Most medical schools have excellent interviewing courses, and a lot of them use standardized patients, and it's very good. Then they get out on the wards in their 3rd year, and they get hammered, because what's the purpose of life on the wards is to get patients in and out quickly. Furthermore, most of the conversations with people in the acute care setting are completely different than those in the outpatient setting. So then, after having none of the good stuff reinforced in the 3rd and 4th year in medical school, they go out and become house officers. Well, then the situation just gets dramatically worse. So in house staff training, there is few, if any, examples from senior or more advanced physicians about how to do this better. The challenges of being a house officer are a lot about getting through the day and getting patients in and out of the hospital. And then when people get out in real practice, there are no more role models. In other words, people actually don't watch each other practice very much. So, so the problem is people are getting some very good training, but they're not getting good reinforcement of those ideas through the sort of process of internship and residency and so forth. So that's why we thought we'd start at the other end, but I think efforts on both sides are critical, and hopefully they'll meet in the middle.
Good, thank you, Ira. And just
and
to follow
by the way, I think you'll find that go ahead.
Go ahead.
No, I was going to say, I think the same is true for nurse practitioner training, pharmacy training, and many other disciplines.
Mm-hmm. Excellent point. And just to follow up on our challenge activity, if you know of schools or associated with school that would like to participate, you can contact Ayana Johnson at the League about that. Last year we had over 60 schools participating, reaching thousands of patients and healthcare professionals. So on to the next question. Ira, this is a question from Patty, and she's wondering if there is a way to approach patients with a history of depression and other mental health conditions, and how does this affect adherence to other meds?
Wow, great question. We do know from good research that patients who are depressed, particularly those who are severely depressed, naturally have a lot of problems taking other medicines. Taking medicines, particularly multiple medicines, is tricky and complicated, and you have to have intact cognition to do that. Depression is a severe disease of the cognitive organ or instrument, the brain, and so it's really quite hard to get patients to take medicines if they're depressed. Let me suggest something that some of you may disagree with or debate. If patients are severely depressed and can only do a few things, having trouble getting up, eating, getting through the day, we have to pick our battles. And the battle that I pick for depressed people is the antidepressant. And if you have a middle-aged person who's being treated for elevated lipids and mild hypertension and things like this, for which there's no really short-term threat, I just don't spend as much time on those medicines, and I focus on the medicines that they have to take in order to get better from depression. So picking your battles, talking to patients really in detail about what the diagnosis of depression is, because as you know, many people really misunderstand it. Making sure they understand the pluses and minuses of medication treatments of depression, which, as you know, there are many minuses. Making sure that they understand the role of counseling or other non-medication approaches to depression. These are all really important, but boy, you got to pick your battles.
Thank you. The questions are coming fast and furious. We're not going to have time to answer all of them. I want to encourage people that to continue the conversation to visit our website, like us on Facebook, follow us on Twitter. I will take my meds to keep getting more additional helpful information. But we are going to end with the last question, and that is a question from Laura. And it's about the role of the pharmacist, which we know through the Scripture Future campaign can sometimes be the most accessible healthcare provider for patients. And the question is, Ira, what do you think about having the pharmacist reinforce the conversation at first fill and calling the patient 2 weeks after first fill to touch base to see if they've experienced any side effects or have more questions?
Well, first, let me say that I think in the ideal world, every primary care practice ought to have a pharmacist or pharmacy expertise integrated into that practice and into that patient-centered medical home. The problem is that the retail pharmacy model really doesn't allow that or permit that. Unless you actually have had a conversation with a physician, if you're sitting at CVS or Walgreens or a retail pharmacist, you don't actually really know why a patient's on an antihypertensive or an antidepressant. They might be on an antidepressant for pain. They might be on it for obsessive compulsive disorder. You don't know if they're on a beta blocker for anxiety or for hypertension or post-MI. So all that we have makes it really difficult for primary care doctors to collaborate in ways which I think are really functional and effective. That said, anything that pharmacists can do to follow up with patients, whether it's a phone call or something, after a new medication is started, is probably very valuable. We don't actually emphasize enough how critical it is to start a new medication appropriately and well. Because for many medicines, if you don't start it well, you may not get a second chance. I've had many medicines patients tell me they tried an antidepressant and it didn't work and they weren't going to try another one. And the reason for that was not that it didn't work, but that they didn't really have an adequate first trial of that medication. And many of you out there know this happens with many medications. So following up to sort of provide support a new medicine, great idea.
Great to have you join us today, Ira, and your presentation and all the questions. And I'm sorry we could not get to all your questions. We are able to answer your questions through Facebook, so I would encourage you to go there and we'll try to get to as many as we can. Again, thank you for joining us today. We are so pleased that many of you were interested in this presentation. We encourage all of you to visit the Script Your Future website to download the slides that Ira used and for more information and helpful tools for you and your patients. You also will all be receiving a survey after the webinar asking you about your interest in future activities. We encourage all of you to respond so we can continue to offer helpful information. Thank you again, Ira, for joining us, and to the rest of you. This now concludes the Script Your Future Medication Adherence in Practice webinar. Thank you.